On your left hand side, there are more dead cells, right? Now, action potential can travel from this side to this side because all these cells are capable of transmitting action potential from here to here, right? But these dead cells, they cannot transmit action potential from here to here, okay? So, it creates a unidirectional block. So, in this example, action potential can travel from right to left, but it cannot travel from left to right, right? So, it is the basis of unidirectional block. Unidirectional block usually occurs because of the presence of dead cells within the myocardium, and that dead cells may arise from different disease, say for example a mild heart attack, right, or any infection, myocarditis, right, okay. So, any disease pathology may give rise to dead cells, and those dead cells will not be able to transmit action potential from one cell to another, and that is the basis of unidirectional block. So, now I guess all of you have the concept of unidirectional block, right, okay. Will you be able to write it down in exam? Okay. You need to draw cells in normal, right, all the cells are normal. So, action potential can travel from left to right or right to left in either direction, right. And here on your left hand side you have few dead cells, and dead cells will not be able to transmit action potential from left to right, but on the right hand side all the cells are normal. So, they will be transmit action potential from right to left. So, in this picture B, action potential will not travel from left to right, but it will travel from right to left. So, it is unidirectional block, okay. So, for unidirectional block there must be presence of dead cells at a place, right, okay. Now, for re-entry we need three conditions, okay. So, what does re-entry means? So, if we understand easily, so a circular fiber, okay, a circular fiber so that essentially means cells, right, that essentially means cells, that is myocardium, okay. So, these are cells, and they constitute a circular fiber, okay. Now, action potential is coming from above, action potential is coming from above. Now, once action potential comes here, it has two avenues, okay, right. So, it is a circular muscle fiber that may happen or that may be present congenitally, okay. It may be due to some structural heart disease, presence of circular fibers. It may arise due to presence of a congenital system, or it may arise due to some disease process, okay, right. ये हो सकता है from the very beginning, from birth, or it may arise, ये हो सकता है due to some disease process. पहले किसी को myocarditis हो गया था या फिर mild heart attack हो गया था, right. So, due to this there may be formation of a circular fiber, okay. Now, once the circular fibers are present in heart, while action potential is coming from above, and once it reaches this point, it has two avenues. It may go in this direction or this direction, okay, and they finally may be united here. It may happen, right, or it may also happen that action potential will travel in this direction and will rotate back in this direction. It may also happen, but nobody knows what will happen, okay. So, anyway, if it occurs that action potential coming down through a path and returning back, so let us assume here is the ventricle and here is your atria, right. Here is the ventricle and here is your atria. So, if a circular fibers are present between atria and ventricle, what can happen? So, from atria action potential is coming, right? So, while entering into the ventricle, it may take a path and it may go back to the atria, right? Normally what happens? Normally here is SA node, normally in heart what happens? Here is SA node, from SA node to AV node action potential comes, then AV node to bundle of His, then right bundle branch and left bundle branch, right? Okay, in this way action potential travels, okay, but there is no returning back of action potential from ventricle to atria, right? This is normal, this is abnormal, right? So, we call it a re-entry circuit if it happens that action potential is traveling above downwards through a path and it is returning back through another path, right? We call it re-entry. Okay, so action potential is essentially coming from atria, depolarizing ventricle and going back to atria, again depolarizing it, right? We know in ECG, P wave is due to atrial depolarization and QRS complex is due to ventricular depolarization and T wave is due to ventricular repolarization, right? Okay. So, what do we expect? So, if action potential is coming from atria, depolarizing the ventricle and going back to atria, again depolarizing it, so what should happen? Again a P wave, because atria is again being depolarized, right? Okay, let us see what happens in ECG. Okay, before that, what the ECG looks like in a re-entry event, your first professional MBBS examination questions will be coming, what is re-entry and what are the conditions to satisfy for the re-entry to happen, right? So, re-entry क्या है और re-entry होने के लिए क्या क्या condition fulfilled होना पड़ेगा, that is the question. Okay, what are the prerequisites of re-entry, right? What is re-entry and what are the prerequisites of re-entry? ठीक है? So, first क्या condition आपको fulfill करना पड़ेगा for re-entry to happen, right? So, number one condition is unidirectional block, ठीक है? ये होना पड़ेगा, right? Next, presence of a circular pathway, okay, presence of a circular conduction pathway, right, presence of a circular conduction pathway, that is abnormal essentially, right. So, presence of a circular pathway, and third, perfectly timed atrial premature complex, right, perfectly timed atrial premature complex, मतलब एक पर्टिकुलर टाइम पे एट्रिया से वेंट्रिकल मतलब उस री एंट्री पॉइंट तक एक्शन पोटेंशियल को आना पड़ेगा, ठीक है, परफेक्टली टाइम्ड एट्रियल प्रीमैच्योर कॉम्प्लेक्स, राइट, एट्रियल प्रीमैच्योर कॉम्प्लेक्स, राइट, ओके. सो आई रिपीट, what is re-entry and what are the prerequisites of re-entry? Prerequisites of re-entry are three, right? There are three prerequisites of re-entry. One is unidirectional block, two is presence of circular conduction pathways, and three is perfectly timed atrial premature complex, okay. So, hardly it will take half a page and you will get marks. If it is out of 5, you will get 5 on 5, okay. So, you need to draw this, you need to draw this circular pathway and write the conditions, explain the re-entry, right, okay. Hardly it will take half a page or maximum less than a page, right. At least I will give you 5 on 5. So, your question at first professional MBBS is what is re-entry and what are the prerequisites of re-entry, correct, okay. Now, we are focusing on the ECGs, how an ECG will look like in a case of re-entry, okay. Actually, there is a broad classification, okay, depending on the presence of re-entry circuit, right, depending on the presence of re-entry circuit. Re-entry circuit, heart हार्ट पे कहाँ पर लोकेटेड है, डिपेंडिंग ऑन दैट वी डिवाइड री-एंट्री phenomenon into AVNRT and AVRT. Okay, so AVNRT, AVNRT. Okay, full form is of the abbreviation is AV nodal re-entrant tachycardia. Okay. Okay, can you please tell me from your knowledge up to date, जितना भी ECG का knowledge आपको हुआ है, आप बता सकते हैं कि what will be the symptomatology in the patient having a re-entry in heart? Patient को क्या problem होगा? Yes, you will diagnose re-entry by seeing an ECG, by interpreting an ECG. But what the patient will tell? You are in a clinic and the patient will be coming to you. Maybe the patient is having a re-entry in heart. What will be the complaint of the patient? Always correlate clinically, otherwise it will be hard to understand. Patient will be complaining of palpitation, right? Okay, now there are many causes of palpitation. Now you need to rule out whether this palpitation is happening at all due to re-entry or not. We will ask about previous heart disease. If the patient is having heart disease, the patient is taking any medication for that, you need to inquire about that patient, whether the patient had any attack of acute myocardial infarction previously or not. So basically you are inquiring about the presence of dead cells, unidirectional block, right? And if re-entry is happening at all, the patient will be having palpitations, right? Okay, now come to AVNRT, means AV nodal re-entrant tachycardia. But the patient will be having tachycardia, heart rate will be more than 100. What is tachycardia? Tachycardia is heart rate more than 100. What is bradycardia? Heart rate less than 60, right? Okay, so AVNRT means AV nodal re-entrant tachycardia. That means the circular pathway is located around the AV node. Okay, AV nodal re-entrant tachycardia, right? Okay, so this is your heart. Right? Where is AV node? Here is the AV node, right? And it says in AV nodal re-entrant tachycardia, the circular fiber is located around the AV node. Clear? The circular fiber is around the AV node, right? So here is your AV node and here is the circular pathway. Clear? AV nodal re-entrant tachycardia, that means presence of a circular fiber. The first condition, okay? The first condition was unidirectional block, second condition was circular pathway, and third condition was perfectly timed atrial premature complex, right? Okay. So this circular fiber is around AV node. What will happen? Okay. Usually the refractory period are different for these two paths. Okay. Now action potential is coming from here, from above, right? Okay. Now we call it slow pathway and fast pathway, right? So this is slow pathway, slow, and this is fast pathway. Why do we call that? Slow pathway is having short refractory period and fast pathway is having long refractory period. S for S, slow pathway, short refractory period, right? Slow pathway, short refractory period. Okay. Fast pathway, long refractory period. Okay. Now, perfectly timed atrial premature complex, that means when action potential is coming from above, traveling from above, once it reaches the upper part of the circular fiber, it has two options. One, to travel through the short refractory period pathway, another to travel through the long refractory period pathway, right. But it is perfectly timed atrial premature complex. It arrives at the point in such a time that the fast pathway is refractory because it has got long refractory period. It will not allow any action potential to travel through this pathway, right. So, when the action potential is coming here, this pathway will not allow, right, because it has got long refractory period. So, ये अभी सो रहा है, it will not take any action potential, ठीक है, I will not accept, right. But this pathway, this slow pathway, it is ready to accept the action potential, right. So, action potential will travel through this pathway, okay. Understand clearly why action potential is not coming through this pathway, because this pathway is refractory, okay. This pathway is refractory, it has got a long refractory period, okay. Maybe after 300 milliseconds this refractory period will be gone, right. But right now it is refractory, right, right now it is refractory, okay. So, it is not taking any action potential because it is in the refractory period, but it has got slow or short refractory period. So, action potential will travel here. Now, once action potential comes here at the lower part of the circular path, once action potential travels here at the lower part of the circular path, the refractoriness of the long pathway is gone, right. Understand clearly, okay. Initially, when action potential was located at the upper part of the circular path, the fast pathway was refractory. It is not accepting any action potential, but the slow pathway was ready to take the action potential. So, action potential travels through the slow pathway, but once action potential comes the lowermost part of the circular fiber, okay, by traveling through the slow pathway, it finds that the refractoriness of the fast pathway is gone. Now, this fast pathway is ready to take action potential, okay. So, from this point action potential will travel in this direction and in this direction, clear or not, ठीक है. Re-entry তে যদি বেশি নাম্বার থাকে তাহলে এটাও লিখতে হবে কিন্তু, রাইট. Say for example 7 marks or 6 marks আছে re-entry তে, তাহলে AV nodal re-entrant tachycardia এটা লিখতে হবে, okay. So, you have a slow pathway and fast pathway. Initially, the fast pathway is refractory, so the action potential will travel through the slow pathway and will reach the lower part of the circular path, right. And once it reaches the lower part of the circular path, it finds the refractoriness of the fast pathway is already gone. Now, the fast pathway is ready to accept the action potential, right. So, action potential will travel backwards through the fast pathway towards the atria, right, and will travel down through the common pathway, right, to activate the ventricle, right. So, what will happen? This will go back and activate atria, and this will come down to activate the ventricle, okay, ventricle, and it will travel go back to activate the atria. So, both atria and ventricle will be depolarized simultaneously, right. Both atria and ventricle will be depolarized simultaneously. Normally, what happens in an ECG? You first see P wave, for atrial depolarization. उसके बाद ventricular depolarization होता है QRS complex, right? So here in this example, atria and ventricle will be depolarized simultaneously. एक ही साथ atria and ventricle is being depolarized, right? So what will you see in ECG? What do we expect in the ECG? P wave or QRS complex एक ही साथ. But P wave is a low voltage wave, QRS complex is huge, right? So QRS complex P को खा जाएगा. You can't see P separately, right? You will only see QRS, 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 right? QRST, 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 QRST. There is no P. Okay? P is there, but it is buried under the high voltage QRS complex. ठीक है? P wave दब गया उसके अंदर, QRS complex के अंदर, right? Because P wave is a very low voltage. ठीक है? QRS complex is a high voltage, right? Deflection. Okay, so what you see in ECG is QRST, 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 QRST and no P. It is called AV nodal re-entrant tachycardia. Patient will be complaining of palpitation, heart rate will be 150 to 200, right? Heart rate will be 150 to 200 and the patient will be complaining of. So when you perform ECG, you see the patient is having palpitation, you see the patient's pulse rate, it is more than 150. You suspect a case of re-entrant tachycardia, you perform the ECG and you see the patient is having AV nodal re-entrant tachycardia, you only see QRST, 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 right? And your suspect is confirmed, right? What you suspect is confirmed, that is AVNRT, AV nodal re-entrant tachycardia. Okay, so it is a case of AV nodal re-entrant tachycardia. You can't see P here, right? So QRST, 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 right? How much is the heart rate here? In previous class I taught you how to calculate heart rate. How to calculate heart rate from an ECG. How to calculate heart rate? Please tell me how to calculate heart rate from an ECG. How to calculate heart rate? Just tell me the formula. Anyone? What is the formula for calculating heart rate from an ECG? It's the basic question. If you can't answer, you'll fail, right? Yes. Yes, 1500 divided by small squares between two R waves, right? So take any two R waves, okay? So these two R waves. So number of small squares here 5, 5 and 5 almost 10 small squares. So 1500 by 10 heart rate is 150, okay? 1500 by 10, okay? See, basics should not be wrong, right? If you are not able to calculate heart rate from an ECG, that is a big mistake. You will be put behind the bars, right? If you can't check the axis, if you can't check the heart rate from an ECG, that is a big mistake, right? Okay, if you are not able to understand a case of AVNRT, people will forgive you, your examiner will forgive you, okay? But if you can't calculate heart rate from an ECG, there is no mercy. In most of the times in AVNRT, AV nodal re-entrant tachycardia, we don't see P wave because P wave is buried under QRS complex. P wave is buried under QRS complex, so we see only QRST, QRST, QRST. But in few cases, but in few cases, the example is not here, it is QRST, 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 right. So, the thing is, in AVNRT, ECG is in 70% cases, it is QRST, 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 there is no P. But in few percentage of patients, 20 to 30% of the patients, it is seen that P wave falls outside QRS complex. P wave falls outside QRS complex. So, QRSP, QRSP, QRSPT, 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 it may happen, right. Anyway, it is hard question, nobody will ask you on that. But remember, in most of the cases, we will get QRST, 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 but in 25% cases, we get QRSPT, QRSPT, matlab P wave falls just outside the QRS complex, right. But as you know that atria is being depolarized from below upwards. Normally, atria is depolarized from SNAD to this direction, okay. I mean, in my heart it is in this direction, right. So, this is the direction how atria is depolarized, but in presence of AVNRT, atria is depolarized, being depolarized from below upwards. So, P wave will be down, right. P wave will not be this, P wave will be this, right, as because atria is being depolarized from below upwards, okay. So, this is all about AVNRT. Nobody will ask you the treatment, how to treat the patient of AVNRT, but still as we are taking a composite class, I should mention 2 points on the treatment as well, okay. So, how to treat the patient of AVNRT who is having active palpitation or heart rate 150 or more, right. So, the first treatment of choice is vagal massage, okay. What is vagal massage? Here you have the vagus nerve and you need to rub it with 2 fingers, okay. So, it will stimulate the vagus nerve, do not do both sides simultaneously, right. So, it will stimulate the vagus nerve, okay, and once vagus nerve is stimulated, it is parasympathetic to heart and it will reduce the heart rate and the palpitation is reduced, okay. So, this is the first thing, we call it vagal maneuver or vagal massage, okay, vagal maneuver that can be performed anywhere. And if the patient is not being relieved from vagal maneuver, the patient should be taken to the ICU and the patient should be given an injection of adenosine, okay. Patient should be given an injection of adenosine, dose is 12 milligram, and if required another 6 milligram can be repeated, right. Anyway, nobody will ask you the treatment, but remember the treatment of choice is vagal maneuver, and if the patient is not responding with vagal maneuver, we give injection adenosine at a dose of 12 milligram and we can repeat the dose after 5 minutes 6 milligram, right. Okay, so this is all about AVNRT or AV nodal re-entrant tachycardia, okay. Now, another very important thing is AVRT. This is AVNRT we have talked about, that is AV nodal re-entrant tachycardia. That means the circular fiber is located around the AV node, right. Circular fiber is, do not look at the picture right now, you will not understand, right. So, it is circular fiber present around the AV node, but the circular fiber may be big enough, right. The circular fiber may be big enough, means it may cover the whole heart, right. AV node is a small part within the upper part of the interventricular septum, right. and a small circular pathway will be there, right? But in case of AVRT, see the normal pathway, the normal conduction pathway is from SA node to AV node to bundle of His. From bundle of His you have the fibers, left bundle branch and right bundle branch, right? This is the normal path, okay. I am not showing the left and right branch separately, okay. So, this is the normal path, right? SA node, AV node, bundle of His. This is normal path, right? Here is the location of AV node, correct. Now, in this category, AVRT, this is called atrioventricular re-entrant tachycardia. Okay, I am coming to it. What is atrioventricular re-entrant tachycardia, right? So, here the problem is an extra conduction pathway connects atria to ventricle, right? An extra conduction pathway lies from atria to ventricle. It is called the bundle of Kent, K-E-N-T, the water purifier, right? Bundle of Kent, right? Okay. Now, from SA node action potential is being generated. Here is the SA node. From SA node action potential is generated. Now, action potential can travel through the normal pathway. It is the normal pathway, internodal tract, SAN, SA node, AVN, AV node, PH, bundle of His, right. So, this is the normal pathway, right. SAN, AVN, BH, this is normal pathway. So, action potential can travel through the normal pathway, definitely, but action potential has got another option. Let us bypass this. I will travel through this direction. This pathway is easier through bundle of Kent. So, action potential has to come from atria to ventricle, right. So, action potential can travel through the normal route, that is SA node, AV node, bundle of His, and come to the ventricle, reach to the ventricle. But in this case, presence of bundle of Kent, it is congenital. Presence of bundle of Kent is congenital. It is a congenital abnormality of heart, right. So, once bundle of Kent is present, action potential has again two options to travel from atria to ventricle. One option is to travel through the normal route, SA node, AV node, bundle of His. Another option is to travel through bundle of Kent, which is faster, through Kent. Why? Because of the absence of AV node. What is the function of AV node? It checks the action potential, whether it is normal or abnormal. It is the police, okay. It will allow only the normal traffic, not the smugglers, right. AV node is the policeman of heart. It will check all the action potential coming from atria and it will allow only the normal one, right, and send to ventricle, but it will stop the abnormal discharge from the atria, right. It is the function of AV node, but it will take time, right. While checking, it will take time, okay. But in Kent path, there is no checking, okay. In Kent, there is no checking. So, action potential, any action potential, irrespective of its quality, it can travel from atria to ventricle without any delay, right. and you know what is PR interval in an ECG. What is PR interval? From the beginning of P to the beginning of Q. This is PR. Clear? This is PR interval. And what does PR interval signify? Yes, very nice. It is the time duration. It is the time duration action potential takes to travel from atria to ventricle. Okay. Now see what will happen if action potential, instead of coming through normal pathway, it comes through the Kent pathway. PR interval will short, right? Matlab action potential will take less time to travel from atria to ventricle, okay? And the ECG will look like okay? ECG will look like this, okay? So this, इसको normally यहाँ पर आके फिर उठना चाहिए था, right? In a normal heart, after P wave, it should go like this, form a Q wave, then it should rise like this. But it is a sign of early rise, right? So you see an early rise, right? This point. Clear? Early rise. Clear? See this ECG. It is due to presence of Kent fibers, right? It is called WPW. What? Have you heard it? It is called WPW syndrome, Wolf-Parkinson-White syndrome. ठीक है? स्पेलिंग देख लेना बुक में. Wolf-Parkinson's-White syndrome. Very frequent short note for your first professional MBBS and very important MCQ zone for NEET PG, postgraduate entrance, right? Okay, now there are some things to discuss. That is, we don't know, anybody may have bundle of Kent, okay? Maybe we are sitting here, it is supposed we are normal, but maybe we are having, maybe someone of us may be having maybe someone else may be having the Kent fibers. How to check? Right? Again, if the patient is having symptoms like palpitations, right? If the patient is having symptoms like palpitations and you perform ECG and you see this, it is called, this early rise, it is called delta wave, okay? This early rise is also called delta wave. Okay? This early rise is called delta wave. An ECG of WPW, and you will be asked to identify the delta wave, right? Okay. So there may be different situations. One problem is that I have the bundle of Kent. I have the bundle of Kent in my heart, but the action potential which is traveling from atria to ventricle, it is not traveling through bundle of Kent, it is traveling through the normal pathway. It may happen, right? So I will not be having any symptom, even if I have the bundle of Kent, right? So ECG में ये पता नहीं चलेगा, right? This is one scenario, okay? And these patients are concealed, ठीक है? ये पेशेंट्स कभी डिटेक्टेड नहीं होता है, ठीक है. So patients will be having bundle of Kent, but action potential is coming through normal pathway, that is SA node to AV node to bundle of his and the Purkinje fibers. So patient will not have any symptoms, number one, and even if you perform ECG, you will not see this delta wave, right? So these patients are called concealed WPW, concealed WPW, ठीक है. WPW है लेकिन वो छुपा हुआ है, ठीक है. And the patients are usually not detected, right? Okay, now next is action potential is traveling through bundle of Kent. Patient को Kent fiber है और action potential is being traveled from SA node to Kent fiber to ventricle, right? So abnormal pathway से action potential atria to ventricle आ रहा है, right? And patient को इस टाइप का ECG भी है. अगर आप ECG करते हो तो पेशेंट का इस टाइप का ECG होगा, बट द पेशेंट इज नॉट हैविंग एनी सिम्टम्स, पेशेंट इज एब्सोल्युटली नॉर्मल, राइट. पेशेंट को पैल्पिटेशन भी नहीं है, ठीक है. सो दीज पेशेंट्स आर कॉल्ड मैनिफेस्ट WPW. पहले हम लोग बोल रहे थे कंसील्ड WPW, केंट फाइबर है लेकिन उसमें कंडक्शन नहीं है. नाउ केंट फाइबर है, उसमें कंडक्शन भी है, ECG भी एबनॉर्मल है, लेकिन पेशेंट को सिम्टम्स नहीं है. वी कॉल इट मैनिफेस्ट WPW, राइट. नाउ द थर्ड पॉसिबिलिटी इज पेशेंट को केंट फाइबर है, एक्शन पोटेंशियल केंट फाइबर से ही पास हो रहा है, ECG भी एबनॉर्मल है और पेशेंट को पैल्पिटेशन भी है. वी कॉल इट WPW सिंड्रोम, ठीक है. सो कंसील्ड WPW, मैनिफेस्ट WPW एंड WPW सिंड्रोम, ठीक है. ओके, स्टिल दिस इज नॉट री-एंट्री. ओके, स्टिल दिस इज नॉट री-एंट्री. नाउ व्हेन री-एंट्री विल हैपन, ठीक है, WPW कोई री-एंट्री नहीं है, इट इज जस्ट द प्रेजेंस ऑफ एबनॉर्मल पाथवे फ्रॉम एट्रिया टू वेंट्रिकल इंस्टेड ऑफ द नॉर्मल पाथवे. ओके, तो री-एंट्री कब बनेगा? री-एंट्री कब बनेगा? जब केंट फाइबर से एक्शन पोटेंशियल ट्रेवल करेगा और नॉर्मल पाथवे से वापस जाएगा, या नहीं तो फिर नॉर्मल पाथवे से एक्शन पोटेंशियल वेंट्रिकल में आएगा और केंट फाइबर से वापस जाएगा एट्रिया में. दैट विल मेक AVRT, right? Right. So it is a big circular pathway, right? Covering whole atria and ventricle. It is usually common in the left side, but may happen in the right side as well, right? So action potential can travel through the abnormal pathway, that is Kent pathway, and move back to atria through the normal pathway, right? This is one case, and another case is action potential will travel through the normal pathway, that is SA node, AV node bundle of his Purkinje fibers, and move back through abnormal pathway or Kent pathway to the atria. Okay, so see this. So this is called orthodromic AVRT, where action potential is coming through the normal pathway and moving back through the Kent pathway, right? We call it orthodromic AVRT. Okay, here there is normal QRS duration, delta wave नहीं होगा यहाँ पर, और retrograde P wave after QRS के बाद उल्टा P wave होगा. So आप देख रहे हो QRS के बाद उल्टा P wave, right? Okay, this is called orthodromic AVRT. Again यहाँ पर treatment of choice is vagal maneuver and adenosine injection, right? Now next is, which is more dangerous and fatal. Okay, this one is more dangerous and fatal. Patients usually do not survive. Okay, so this is antidromic AVRT, where action potential is coming through abnormal pathway and going back to atria through the normal pathway. We call it antidromic AVRT. Okay, antidromic AVRT, where QRS complex is wide with presence of delta wave, right? P wave is usually not seen. right? And here adenosine is contraindicated, यहाँ पर adenosine देना नहीं है, vagal maneuver भी करना नहीं है, ठीक है? Here there are different, it may frequently, it is confused with VT, ventricular tachycardia. Anyway, these details of treatment you don't require right now, okay? Just remember this is much more serious condition, okay? So this is all about AVRT. So it makes your re-entry class complete. Your question is, what is re-entry? What are the prerequisites of re-entry? Okay, and classification of re-entry, classification and further explain re-entry. And under re-entry phenomenon, you give example of AVNRT, how the ECG look like, and what is the pathophysiology of AVNRT and what is the pathophysiology of AVRT. Okay? And study WPW syndrome separately. It is a frequent short note for your first professional MBBS examination. WPW syndrome and delta wave. Okay?